Welcome to this lecture on Chiari malformation from Dr. George Jallo. This lecture is aimed at family physicians, emergency room physicians, and pediatricians. Chiari malformation is a complex condition, and its management remains controversial. It is an honor and privilege to have Dr. George Jallo deliver us this lecture. Dr. Jallo is a doyen of pediatric neurosurgery. He's a consultant pediatric neurosurgeon and the physician-in-chief at the Johns Hopkins All Children's Hospital in Florida. He's also a full professor of neurosurgery at Johns Hopkins University. I'm looking forward to his lecture, and I thank you for viewing this lecture. If you have any questions, please do not hesitate to contact me or Dr. George Jallo. Thank you.
Good morning or good afternoon. I do want to take some time and speak to you about what you need to know about Chiari malformations. So first of all, what is a Chiari malformation? Is it a malformation or is it a deformation? There's been a lot of controversy recently in the neurosurgical literature recognizing that this may not be a malformation, but rather a deformational abnormality that involved the contents of the craniocervical junction. And it's really where the hindbrain or the tonsils herniate through the foramen magnum, that opening in the bottom of the skull, which then create a continuum of issues and symptomology. And really, depending upon the degree for the herniation as well as the clinical presentation, there are multiple types. But before we begin, just want to give a little background. We call it a Chiari malformation, although it was recognized by another pathologist in 1883 before Hans Chiari recognized it in 1891 in a postmortem study of 40 infants and described it as the Chiari malformation. And over time, it was previously called the Arnold Chiari, but with subsequent recognition that it was really Chiari that identified it. And when we talk about Chiari malformation, there are several types. Chiari 1, which is the simplest form, is the caudal displacement of the cerebral tonsils through the foramen magnum. Chiari 2 is what's recognized as the Arnold Chiari malformation with some brainstem dysfunction and may involve more than just the tonsils, but the fourth ventricle as well as the medulla that is herniating down through the foramen magnum and is associated with monomeningoceles, hydrocephalus, and stringomyelia. The other is really the Chiari 3 malformation, which is considered incompatible with life and may not be recognized as Chiari, but more like an occipital encephalocele with the associated finding of hydrocephalus. And the severity of symptoms really depends upon the degree of the herniation of the cerebellum or brain that is coming out of the skull. And finally, there is the Chiari 4 malformation, and then others that are called Chiari 0, where there's a normal posterior fossa, but they have symptoms of the Chiari 1 malformation. And more recently, Chiari 1.5 is where there's some a moderate degree of brainstem herniation, which which correlates with the Chiari 1. At the end of the day, we really should call them Chiari malformations. and not worry about the Chiari 0, Chiari 1.5, or 1.0. So it is the descent of the cerebellar tonsils into the cervical spinal cord. And you typically do not descend below C2. There is no associated spinal dysraphism, can be associated, but on rare occasion with hydrocephalus. There are some associated anomalies of the skull base, such as basilar invagination or metaplasia, and syringomyelia fluidans at the spinal cord is seen in up to 3/4, or somewhere between half to 3/4. And these children can present with scoliosis. And we can see here, the normal position of the cerebellum and the flow of CSF around the spinal cord. And in the Chiari, the tonsils have descended down and limits the flow of CSF and the development of syrinx with the CSF pulsations. Here, I think, is an artist's depiction of that. You can see the top of the head, the skull, and the brain, the cerebellar hemisphere, as well as the tonsils. And you can see the foramen magnum there, as well as the brainstem. And as we see descent in the Chiari malformation through the foramen magnum, which may put some compression of the upper cervical cord and the medulla, and the obstruction of CSF, as evident here in this artist's depiction, seeing the tonsils go below the arch of C1 and up to C2, and the obstruction of CSF flow and the creation of symptoms. Now, in this the artist's depiction, you can see the foramen magnum, the spinal cord, the CSF flow, as well as the cisterna magna. And then with Chiari malformation through the foramen magnum, you can see the spinal cord and the kinking of the circummedullary junction and the obstruction of the CSF pathways. On this autopsy study, I think it's quite evident. These are the tonsils that herniate out, and this is a lower. And again, what you need to recognize is that they're not symmetrical. One may descend lower than the other during this depiction. So what is the natural history? A lot of times it's largely unknown. There are some reports that the tonsils can ascend with age. And I think what we need to define is that Chiari malformation is a radiographic diagnosis of the tonsillar herniation. And it's insignificant in the absence of symptoms and or syringomyelia. So what happens? It's usually seen in second decade of life, and could be a mean age around 40, but can be seen anywhere from the young infants to 70 years of age, slight female predominance, and that the incidence has increased with the advent of MRI, so magnetic resonance imaging, which is gold standard. So what are the theories? Some theories are that the cerebellum is pushed down from above. It could be pulled down from below, such as in vomiting a cerebellar cord. Could be craniosspinal pressure dissociation or the loss of CSF. But I think, in terms of what is it, I think the key is recognizing the syndromes or the symptoms, because this is the great imitator. And I like to break it up into three different categories. I think, the first is foramen magnum compression syndrome, and it is. It really is where they may present with ataxia, some lower cranial nerves, and some headaches. The central cord, secondary to the syrinx, can cause some sensory loss and lower cranial nerves, and then the cerebellum, which is unsteadiness, ataxia, imbalance, some net downbeat nystagmus, and can be associated with some horizontal. So in terms of symptoms, the headache, pain is usually the headaches are in the back, and this is seen in up to 2/3. Headaches are specific to the back of the head or the upper neck, and it's triggered or exacerbated by Valsalva activities, straining, or not. Motor deficit, again, very unusual, but can range from a slight unilateral deficit to quadriparesis. And in young children and infants, feeding problems or central apneas may be presenting features. In the young children, sleep study is helpful. Looking for central sleep apneas more so than obstructive apneas. As I said earlier, it's really the key and gold standard to MRI, not CT or X-ray. And it's the tonsils are below the foramen magnum, as you can see in this line here, drawn horizontally in this red. If they descend more than 5 millimeters below, that is consistent with a Chiari malformation, and that if they are somewhat pointed, as evident here, and that there's crowding of the CSF. Sometimes neurosurgeons may recommend a cine or flow study to look at the CSF flow pathways, and we will image the spine to rule out serous or fluid inside the spinal cord, as evident here. So X-rays, CTs, they could be normal and up to 70%, and may see some of the bony abnormalities, such as basilar invagination, and atlanto-occipital assimilation, widening and spinal canal, agenesis of the arch, or scoliosis. What you read is a cerebral ectopia on the radiology report is not a Chiari malformation by any means. So what is the treatment for Chiari malformation? One, there are multiple methods to treat this. There is a posterior cranial vertebral decompression with or without aduroplasty, drainage or plus or minus drainage of the syrinx, or diversion of CSF. So I think there are many variations to treating this as the gold standard. Posterior faucet craniectomy with or without removing the C1 laminectomy, and we'll discuss that. A large posterior faucet craniectomy, opening or not opening the dura. Do we shrink the tonsils? Do we sew and graft? And what do we do about the syrinx? So, my treatment paradigm here is that if you have a symptomatic Chiari, rule out hydrocephalus or other compressions, and then see if there's a syrinx or not. If there's a syrinx, regardless of symptoms, Chiari decompression is warranted. If there's no syrinx, assess, is there more than 5 millimeter descent? Is it less than 3? Because if there is less than 3, this is cerebral ectopia and not a Chiari malformation. And 3 to 5, you really need to exercise clinical judgment and or the symptoms associated with that. So the technique is really to make the posterior fossa larger. Here is normal. This is a Chiari, tonsils down. Here's the syrinx. And really the approach is from the back if one's going to remove and do the operation. And typically the children are in the prone position or on their stomachs. And the incisions, you can see, has to span the suboccipital region as well as C1. And then usually the standard opening is somewhere between 2 to 5 centimeters. I tend to do 3 centimeters to open up the foramen magnum and then remove the arch of C1. If we're going to open the dura, it's typically opened in a Y-shaped fashion. You can see here the dura has been opened. These are the tonsils that have descended down. Sometimes we will shrink the tonsils to have them slide up. And then we will sew in a graft, as evident here. And there are many different types of materials, from autograft, someone's on pericranium, to allografts, and a whole host of different materials. In this animation, we will describe you will see the procedure. Here's the back of the head, patients laying down, shaving the head minimally, mapping out the incision, and then dissecting the muscles, getting down to the bone, and then doing that opening over the foramen magnum on the suboccipital region, removing the arch of C1 as well there, and it's just a partial removal of the first cervical vertebrae. And then you can see that in some cases, this immediately expands the CSF pathways and relieves the compression of the cerebellar tonsils. If that is not adequate, using ultrasound or observation, one would open the dura, as evident here, and then sometimes coagulating the tonsils there, and then sewing in a graft to make the duroplasty. So what are some facts? If one just does the bone decompression only, it's a shorter operation. If one does a bone decompression with a duroplasty, it takes twice as long. Blood loss is about the same. Risks are a little higher opening the dura with infections, mild fluid leak, and wound healing, longer hospital stay, and higher risk for complications, but a less likely need for reoperations. And there are many variations of the theme, and there's really no consensus what is the best. So what are the complications? There are many reports in the older literature of up to 50% of mortality. Morbidity is small, but there is risk of injury to the blood vessels, and some risk of respiratory depression within the initial 36 hours with spinal fluid leak, fluid collections, or aseptic or septic meningitis. In terms of outcomes, when one considers the outcomes treatment, usually the pain, headaches are most likely going to improve. Weakness stabilizes, does not improve, and the cerebellar symptoms typically improve in 80% of the time. There are considerations for reoperations for these Chiari malformations, as patients may represent, and this is typically seen in children, younger children who undergo bone-only decompression and not at a young age and not duroplasty. They may develop scar tissue or regrow of their reossification of their bone and creating new symptoms. So I think to conclude, with an adequate decompression, the symptoms improve, recurrence is minimal, and the risk factors are young age, insufficient decompression, complex bony anatomy, or other syndromic features. And how long we follow these, we're not, no real significant data on how long some of these patients need to be followed. And again, I think this is just looking at the a recent meta-analysis of over 1,200 patients, both children and adults, and some of which had syrinxes. You can see that the outcomes with just the bone only improved 74%. If you do a duroplasty, it's 82%. Tonsil coagulation, it's really close to 90%. So the more invasive you become, the more success that becomes. So hopefully, to summarize, I think really the key points, take-home messages: MRI is gold standard. CT can suggest Chiari, but you really need an MRI of the brain surface spine to confirm. Subarctopia of the tonsils as they descend is not a true Chiari. Headaches are occipital and stress-induced, not frontal. Surgery is not emergent or urgent unless an acute neurological, and there are many surgical approaches to resolve these symptoms. Thank you for your time, and look forward to any questions.